today to talk to you about hypoglycemia and continuous glucose monitoring, a new frontier. The objectives are fairly simple. First, we're going to explore the definition and treatment options for low blood glucose in the newborn. Secondly, I'm going to talk to you about why 72 hours of age is an important threshold for hypoglycemia. And third, which is what you're really here for, is how might we use continuous glucose monitoring? This is something I've had an interest in for some time. As you may know, the Canadian Pediatric Society has a statement, which I co-wrote, on the topic of neonatal hypoglycemia and its management from 2019. One thing that's important to note is that physiological decreases in glucose is normal in the first 48 to 72 hours. Persistent neonatal hypoglycemia, though, is an indication of pathology. Sometimes it's difficult for us to distinguish between what's persistent versus what is transitional, as that placenta is cut and the baby needs to start making their own glucose. It is important, however, to recognize what is true persistent neonatal hypoglycemia, because that may have, as you'll soon see, negative effects on development. However, coming up with a definition of hypoglycemia as a cutoff is controversial. Is it clinical manifestations, such as jitteriness, or is it the physiologic response that we see if we take markers such as cortisol, growth hormone, or insulin during the time of the hypoglycemic episode? So what about developmental delay? Is it actually the level that's important? So is it having a glucose under 1 or having a glucose under 2 that's important? Or is it the duration? Does it matter how long the hypoglycemia persists for? Finally, what disease? For example, some infants with Beckwith-Wiedemann syndrome or other forms of congenital hyperinsulinism may have persistent hypoglycemia, and maybe that's what leads to the problem. Or is there something associated simply with having certain disease states that leads to developmental delay? A glimpse into how long it takes for an exposure of hypoglycemia to lead to long-term injury was from Alan Lucas back in 1988. He looked at preterm infants under 1,850 grams with a mean gestational age of 30.5 weeks. What he noted was that after 5 days or more of hypoglycemia, these infants were at an increased risk of developmental delay. Importantly, the threshold for this was when their glucose was less than 2.6. So one needed to have 5 episodes in the first 2 months to be associated with delay at 18 months and at 8 years. So we know that you needed multiple episodes on different days to predict a risk of developmental delay. Further information can be gleaned from this study from 2018, looking at outcome from moderate neonatal hypoglycemia from 2 to 6 years of age. This study defined hypoglycemia as a level under 2.2 millimoles per liter, with a goal in these infants being greater than or equal to 2.8 millimoles per liter. When you look at the risk of any neurological or neurodevelopmental outcome, and you look on the far right at the adjusted logistic regression analysis, you see an odds ratio of 1.48 for the presence of hypoglycemia impacting long-term developmental outcomes. So this gives us an inkling into a level that under 2.2 could be hazardous. If you look at some of the other markers or other categories of developmental delay, you'll see similarly several lines there that indicate an increased odds with hypoglycemia that's persistent under 2.2 and has follow-up between 2 to 6 years of age. When one looks at the timing of hypoglycemia and the impact there, you can see that early hypoglycemia for any neurological or neurodevelopmental outcome has an odds ratio adjusted of 1.94, which was statistically significant. but not for late hypoglycemia. However, when you break it down into categories such as any developmental delay, it becomes significant. Motor delay, while not significant, was significant for cognitive developmental delay, whether it was early or late. So it may not just be early hypoglycemia we need to watch out for, but also late hypoglycemia. When it comes to defining what normal is, this has been a challenge that has eluded doctors for a long time. If you go all the way back to 1965, Kornblath talked about this when he mentioned that these levels were elusive. This is from the New England Journal of Medicine, and talks about how it is difficult to find an actual level. But what did he find? When he looked at both preterm and term infants, what he found, and this has been replicated as you'll soon see, is a gradual increase between 2 to 3 days of age in the serum glucose for these infants, whether they were full term or preterm. Interestingly, the preterm infant, which has been shown to be a little more resistant to the effects of hypoglycemia, tended to have lower serum glucoses. And you can see they were between just around 2.8 to start, and for terms would rise up to 3.3 generally by that 48-hour point to 72 hours. But this gives us an idea that there's a natural increase in glucose in the serum that occurs between 48 to 72 hours. The GLOW study by Harris, you may be familiar with Dr. Harris from the work on glucose gel, looked at newborns, 67 infants in a prospective fashion, who were not at risk in the first 5 days of life. So what she was trying to get at was, what is normal for normal infants in terms of their glucose patterns in the first 5 days of life? So these are not infants who are SGA or LGA or infants of diabetic mothers. So what actually happens? What's interesting about this study is they did both intermittent heel prick testing 4 times in the first 24 hours and then twice daily, and continuous glucose monitoring. The reason they did the heel pricks was because in those years, you needed to calibrate the glucose monitor with the intermittent samples. That is not required anymore. What they found was, some 40-something years later, was that things have really not changed. Between 48 to 72 hours, whether you look at plasma glucose on top or interstitial glucose on the bottom, there's a natural rise between 48 to 72 hours. The question, though, is what is happening between pokes? We know that many units will check glucose every 3 hours to every 4 hours or 6 hours. What about the time period in between? Well, that's where you can use either the Medtronic device pictured on your right or the Dexcom device pictured on your left. And you can look at having interstitial samples of glucose to give you an idea of what's happening all the time, as opposed to just at intermittent sampling that is the choice of the practitioner. In terms of application of the devices, they are simple to apply. They go in subcutaneously. They can be used for up to a week. There is a device which inserts them in a subcutaneous placement, generally on the thigh in the preterm infant, and then it is covered and wirelessly transmits to the receiver so that you know what the glucose is. Now we get into some more studies using the continuous glucose monitor. This study by Wheeler is really one of the first back in 2015, in which 48 very low birth weight infants who were under 1,500 grams were monitored for a median time of 72 hours. What the study found is shown in the figures and is very interesting. When you can look at number of hypoglycemic episodes per patient, the capillary sampling, which was intermittent, shown on the left, picked up far fewer than the continuous glucose monitors. Figures B and C are representative samples from 2 patients, one of which had, as evidenced by the black dots, had 3 samples done, and this infant had relatively stable glucose levels. And you can see that the glucose levels stayed above the threshold of hypoglycemia for the vast majority of the time. Whereas a patient like patient C, if you only did intermittent sampling, you see 2 samples there, both above the threshold, which is a dotted line, demonstrating that the patient would have appeared to have not had hypoglycemia, but lo and behold, in the green circle, you can see that in fact the baby did have hypoglycemic episodes. What they found overall was that there was a decreased duration of hypoglycemic episodes per patient of 44 minutes versus 95 minutes, comparing the intermittent sampling to the continuous sampling. Samples, however, were reduced by the use of continuous sampling because, as you might expect, if you know that the continuous monitor is showing that the glucose is okay, you don't feel the need to sample and check the glucose. Interestingly, these studies, though, were not seeking to look for hypoglycemia as much as they were hyperglycemia. The preterm infant, especially the very low birth weight infants, are susceptible in the early days to the development of hyperglycemia. This carries with it short-term complications of IVH, dehydration, electrolyte imbalance, NEC may be associated, ROP has been linked to high blood sugars, BPD, impaired immunity, and poor wound healing. Importantly, in the long term, possibly related in great deal to the short-term complications, there is an association with an adverse neurodevelopmental outcome, as well as long-term insulin resistance. So an Italian study back in 2017 looked again at a similar size group of infants, 50 infants under 32 weeks, under 1,500 grams. And this time, what they looked at was doing an RCT within 48 hours of birth, comparing continuous glucose monitoring unblinded for treatment decisions versus use of intermittent pokes with blinded CGM. In other words, they were trying to determine whether the use of CGM made a difference in terms of care. And what they actually found was somewhat surprising, I would say, but also interesting in terms of what it may mean for future care in the NICU. The target glucose in this case was 4 to 8 millimoles per liter. And in the middle, you can see time and target. The blue bars represent the unblinded use of the CGM. And statistically speaking, there was a significant increase in the percentage of time babies were within the target range compared to intermittent sampling. Importantly, severe hypoglycemia and moderate hypoglycemia were also reduced if you had the CGM in place. While moderate hyperglycemia was not different, the incidence of severe hyperglycemia, which again can be associated with BPD, necrotizing enterocolitis, long-term neurodevelopmental outcomes, was higher in the group that had intermittent sampling. So this would give you some evidence that you can reduce the risk of hyperglycemia and hypoglycemia with the use of CGMs. When you look at the tightness or the variability in the serum glucose or the interstitial glucose, you can see, as represented in blue, the blue section is the unblinded and the red section is the blinded intermittent sampling. There was a greater likelihood of tight glycemic control if you knew continuously what the glucose levels were in your patient. This then leads in 2021 to further work in this field using the REACT trial, the real-time continuous glucose monitoring in preterm infants trial. This was a randomized trial, a bigger sample this time of 182 infants randomized to either CGM or standard care within 24 hours of delivery. They used the CGM for the first 7 days of life and included a similar group of babies under 1,200 grams for 34 weeks. The primary outcome in this case was proportion of the time the glucose was in the target range of 2.6 to 10. In this case, they used the Medtronic sensor. And in speaking with Dr. Beardsall, it's because in the preterm infants, they felt that this was easier to insert. When they looked at the outcome of interest, time in proportion of time between 2.6 to 10, as you can see, the mean percentage of time was 94% in the CGM group versus 84%, so a 10% benefit, and that was highly significant. Similarly, the proportion of time that the sensor glucose was in a tighter range of 4 to 8 was 74% versus 62%. So the use of continuous sampling kept the glucose in a tighter range than the use of capillary sampling. When you look at outcomes, in terms of medications received, no difference in inotropes, antibiotics, caffeine, morphine, corticosteroids, or insulin. What was different, though, and may explain why the target was attained more frequently, is that the daily intravenous glucose was in fact different. In order for the glucose to be kept in the right range, the mean glucose was 9.9 versus 9.2 in terms of grams per kilogram provided per day, and that was significant. So in other words, use of continuous glucose monitoring more accurately predicts what your glucose needs are for the day. When you look at the outcome in the first 7 days, another way to look at this is infants who were given the continuous glucose monitoring were in the target range 13 hours more than the cohort who only received intermittent sampling. And in terms of that tighter target range of 4 to 8, it was 17 hours more. As I mentioned before, there's a risk of necrotizing enterocolitis with hyperglycemia. And interestingly, the rates of NEC were high in this group. These infants, again, were under 1,200 grams. But it was 13% of the 75 infants in the standard care group versus 28% of 85 who had the intermittent sampling. So in other words, reducing the risk of hyperglycemia may have led to a reduction in NEC. Feasibility of automated insulin delivery guided by continuous glucose monitoring in preterm infants is another study. It's a follow-up study by Dr. Beardsall. And the cup on the right is the holy grail, as I like to call it. This is perhaps the holy grail, the idea that you could have an afferent loop sensing glucose, going to a computer, and then determining how fast an insulin pump should run in order to maintain tight glycemic control. We already have this technology in use in adults, so why not in infants? So she did a pilot study looking at 20 patients using an automated system based on CGM data. She looked at this over a 48 to 72 hour period versus using a paper-based algorithm to make changes in the dextrose and insulin infusions. Again, she used an elite sensor. As I mentioned, it's easier to insert in this age group. And she used 2 Alaris pumps, one with 20% dextrose and the other with insulin. And this time they aimed for a target of 4 to 8 rather than the 2.6 to 10. So the goal was that tighter control of glucose. So what did they find? What they found was actually quite shocking. When you used the closed loop system, and again, this is just a pilot study, but even then, with such a small sample size, 91% of the time they were able to keep these babies in target range compared to 26% of the time when they were using intermittent sampling with manual calculations on what to put the insulin to. This is remarkable. This is an almost 4-fold difference in the amount of, or percentage of time that infants were actually getting the right amount of dextrose and insulin in a combination. And this is probably related, you can see, although it's not significant, what you can see is a couple of things. You can see, number one, under insulin, that even though it's not significant, again, it's a small size, the amount of insulin in units per kilogram per hour was twice that of what was in control. And you can see that the mean sensor glucose, when we were trying to keep it between 4 to 8, was 6.2, so right in the middle compared to 8.6 with intermittent sampling and manual calculations. Now, what does the expert have to say? This is a picture of Dr. Beardsall, and I've met with her virtually and talked to her about our considerations of starting to do this here in Winnipeg, Manitoba. Some of the challenges that she wanted to share, and I'll share with you, they wanted to study hyperglycemia and not hypoglycemia. From the adult literature, they knew that the use of the meters is a little less reliable when the glucose is less than 3.5. But one of the things she commented on is you need the confidence of the unit. And what she means by this is, for those of you who have used transcutaneous PO2 or PCO2 monitoring, you would know that in some units, the amount of time or the amount of pokes that you do because you don't believe the results you're seeing can be higher sometimes than they would have been if you had not used that technology at all. If you use it and you believe the CGM data, the good news is, that, as we saw in another study, the sampling should reduce. The other question is, does tighter control result in better outcomes? I think I've shared with you some data to suggest it just might. In terms of next steps, here in Winnipeg, we would like to begin a study looking at larger babies, those who are at risk of hypoglycemia, and see if we can reduce the number of painful pokes. We know that poking of newborns can lead to long-term differences in their perceptions of pain. We also know that you can damage the heels and wind up with quite swollen, bruised heels from the number of pokes that we need to do. And so this is something that we are going to embark on soon. So in conclusion, I think avoiding both hypo and hyperglycemia has benefits that I hope I've demonstrated to you in preterm infants. I think it's pretty clear that we need to stop thinking about a one-size-fits-all approach for glucose homeostasis and management. And we have to recognize that babies between 48 to 72 hours may have different needs in terms of what their expected glucose level should be. I think continuous glucose monitoring has been demonstrated to be feasible now in preterm infants, and the time has come to start looking at the more frequent infants that we see with glucose problems, which is our large infants or our near-term or late preterm infants. And so I'm eager to share that data with you once we embark on that. And I thank you for your time. What are the references for this presentation? And thank you very much.